Okay, well, we will make a start and welcome to you all. It's lovely to see you all. It is a grey day, but you know, there we go. We have had some sunshine, so we can't complain, I think. We have some formal apologies this morning, so I've received apologies from Paula. I think she'd much rather be with us because she's had to go to an emergency dentist appointment. So I've no doubt she would rather be here than there, but clearly she has to go and do that. Any others, Anne, that you're aware of? Or
yes, we've got Dev. I think Carol is only here for part of the meeting. Jan McCarrick and Stuart, unfortunately, late apologies yesterday because he's had to get involved in a CQC inspection this morning.
And thank you, that's lovely. And Nicola's also indicated that she can come to this part, but not to the private part. Okay, so do we have any declarations of interest specifically for this meeting that people haven't let us know about already? No, that's good. So can we look then at the minutes of the previous meeting? So this was the meeting.
Anna,
yes,
sure. I didn't get my hand up quick enough. I don't know if it is Neil James on the line because his role has changed. It might be better perhaps even to do that by email if he's not here to say that. But
he should be here. Neil, are you there?
Yeah, I am. Sorry, I'm trying to find my buttons as well. Yes, sorry, yes, I am. I think I have notified already, but I need to. I did, Anne, didn't I?
Yeah, you sent it to me, but it'd be worth saying no.
Yeah. So, I'm still at the University of East Anglia, but my role, I'm now the university's academic director for taught programs. So yeah, which means it's sort of across the whole of the university, looking at all taught programs, quality assurance, and learning experience for students.
Congratulations. Sounds very exciting.
Sorry, didn't mean to talk for you, Neil. Sorry.
No, that's okay. No, it's fine. Thank you. It's because I'd sent it in. I didn't think I needed to mention it. So, but you're right. I should have done.
No worries. Okay, so we're on the minutes then for the meeting of the 13th, and for accuracy, if we may. So if we can take page 1, 2, 3, 4 and 5. Jane.
Yes, on page 2, which is Anna's report, on the second point, the end of the second point, it says in the region to support. I presume that meant one another and not one other.
Yes, indeed it does. Well done, well spotted. Thank you. So with that amendment, are there any other changes? If not, are we happy to approve those minutes? Thank you. And we'll go on to the actions, but I think they're green, so there's nothing to discuss there. Is everyone happy that we can move on? So we now come to the meat of this public part of the meeting, where we talk to you all about the work that we've been doing within the hospital. And we're very, very lucky this morning to be joined, I hope, by Renee. Is Renee here this morning? Is that where we're going to start, Anne? Is that correct? Yeah. So Renee Gray is our orthopaedic therapy team leader. So he gets involved in, he's a physiotherapist, but I'll let Renee do all of that description. So morning, Renee, and thank you so much for joining us this morning. I believe you have a presentation you're going to share, is that right?
Yes, I'll try and do that now to make sure I can make it work.
Of course, lovely to see you.
Yes, you too, and thank you for having me. I know I was supposed to come in November or December, but I was otherwise engaged, so I think you had stroke instead, which I'm sure they provided a good presentation for you. Okay, let's see, is that on?
Yeah, if you go up to full screen, that's perfect. Lovely.
Screen. Okay, that's excellent. I think, yeah, I can't see my notes on this computer compared to the one I had before, so I know most of it off by heart. So if I start to ramble, forgive me. So I'm on. Oops. And let's have a go back and slide. Sorry. See, I need Yeah. Okay. So yeah. So my name is Renee Gray. I'm physiotherapist in orthopaedics. My interests are in orthopaedics, frailty, and management of elderly patients. And yeah, thanks for having me today. So again, in terms of time, I wasn't given too much time. I think I could probably talk all day, so trying to cut it down was quite hard. And this is just an overview of what we do as a team. So we're quite a small team of physiotherapists, occupational therapists, and therapy assistant practitioners. And this is a bit of almost a mind map of all the areas we cover and what we do within the hospital. But for today and for time limitations, we'll just stick to one area, which is femoral fracture or hip fracture management. So we're involved in the inpatient pathway for this, the femoral fracture best practice committee, and responsible to input data for the NHFD, which is the National Hip Fracture Database, which looks at best practice across the country. So we provide a 7-day service with therapy at the weekends as well. So for those who may not be familiar with femoral fractures, the femur is the biggest bone in the body, or the longest bone in the body, and it's quite a common and increasingly popular bone to break with an aging population. More people, it's gone from 70,000 to over 100,000 in 10 years, the number of people suffering this injury. So it used to be just the neck of femur. Now the standards are applied to the whole femur, which gives much better equity across patients. So here's a couple of gruesome images to give you an idea of what a fracture to the femur can look like. These are expertly fixed by our surgeons, and then it's down to the nurses, the physios, occupational therapists to then look after these patients. But although there's the physiology and anatomy attached to it, the most important part is the patient who is attached to the bone. So this is where things get complicated. Lots of patients who suffer a femoral fracture will have dementia, early stages or late stages of dementia, will have frailty of some degree, may have had a history of falls, and this is an unplanned injury. So compared to a total hip replacement that someone would have electively, which may have a length of stay of 2 or 3 days, as this is unplanned, it's much more traumatic, it's a lot harder to manage for these people, for these patients. Following surgery, again, most people who have a hip fracture will have it fixed surgically, and most people will suffer one or more of these issues. So pain is quite a big thing. Fear, anxiety, these are the things that are often the hidden part of this injury. You can fix a bone, you can stitch it up, you can give painkillers, but if someone's had a fall, they're going to be suffering a degree of sort of post-traumatic stress, really, of realizing that they are fallible. These people have been independent normally up to this point, having had a fall and broken a bone, potentially lying on the floor for a long time. They come to the realization that they can break things, and that can lead to a lot of avoidance of doing certain movements, which is where we come in. There's a massive functional impact on these patients. Someone who could have been walking with a stick or independently the day before their break are now requiring hoists or stand aids to be able to get out of bed in the early days. Post-op delirium is a massive risk factor for a lot of our patients. It's linked with the anaesthetic, with the change of environment from home to A&E to a ward, and with dementia. And this is something which can really increase patients' length of stay and long-term disability. Things like constipation and hypertension are also issues that are either the cause of coming in with a fall or are related to the post-surgical medications and things that people have. So these are things we have to bear in mind when we're managing these patients. And okay, the national acute average length of stay was around 16. I think with COVID that's come down to about 14 days this year overall, but it is quite a long length of stay for most of these patients. So there's lots of good evidence out there and guidelines and national standards related to hip fracture. These are all open to the public, anyone can look at these. The National Hip Fracture Database compare every trust in the country across a whole range of metrics, and therapies are a big part of this. There's also NICE guidelines, Getting It Right First Time documents, the Scottish standards and the Royal College of Physicians. And basically the summary of all that is that having therapy early, having therapy often with specialists, which is patient-centered, lead to the best outcomes. So there are several things that we are monitored on monthly and looked at across the year. So having physiotherapy assessment by day 1, being mobilised out of bed by day 1, being assessed for post-op delirium, and more recently having 2 hours of therapy in the first week as a new standard. It's also important to think about getting people back to their own residence. A lot of patients can't following this injury due to the seriousness of it. And also mortality. There's a high mortality rate in this patient group in the first year and in the first month. And they're all things that we can help with. And the Royal College of Physicians summed it up nicely with the more therapy time invested in the first week, the more likely it is that people would return to their own homes. So in a nutshell, the more we can provide in that first week for people, the more chance they have of returning back to their normal function, which everyone should have the opportunity to do. So there was the largest national audit of rehabilitation in 2017, which looked at all the trusts across the country at hip fracture rehabilitation. We participated in this as well, and these are the 7 standards that came out of that. The first 4 are the ones that we, wrong way around. The first 4 are the ones that are more important in the acute phase. So having, number 1 was having a physiotherapy assessment by the day after surgery. And this is to help overcome real-time issues with mobilising. A lot of the times in hospital, if a patient has low blood pressure, the nurses quite rightly will be saying, low blood pressure, stay in bed, IV fluids. We're more of a risk taker, going, actually, let's sit them up on the edge of the bed, give them a drink, try and get some exercises. Does their blood pressure come up? Can we now try it? It doesn't always work, but a lot of the time we can increase that amount of people getting out of bed by day 1. Standard 2 is looking at mobilising out of bed by the day after surgery. So this can be anyone in the team. It doesn't have to be just the physiotherapist, although we help to facilitate that. Standards 3 and 4 were related to the amount of rehabilitation patients received in that first week and the second week if still in an acute trust. And the focus of this is about having clear rehab goals, looking at strength and balance training to help to avoid further falls and return someone to some degree of independence as quickly as possible. So what we did is, following the national audit in 2017, we completed our local audit in 2019 to compare how well we'd improved. What we'd done after 2017 was really reflect on our outcomes with this measure, and we did poorly. So the national average was 120 minutes in the first week. We were providing an average of 64 minutes, so half of what the most places in the country were providing. So we had a look at how we could improve that, and the 3 things we looked at that we could do were having earlier integrated occupational therapy assessments, so having OTs see patients a lot earlier in their journey, and also alongside physiotherapy, so more joint assessments, more decision making between two therapists with the patient to really see how we can get these patients home earlier. Ward Board was a new system that was introduced around the time we were thinking about this in 2018, and we fully embraced this as a system. We thought it fitted well with what we were trying to do, and then I developed something called a 7-day decision point. So I'll explain a bit more about that here. So this was looking at how we used to do things and reflecting on that. So generally a patient would have a hip fracture, have their surgery within the next day. Physio assessment would happen the day after this, and you would have physio across that 2-week period to try and improve someone's mobility and function. And the occupational therapist would get involved towards the end of this. We'd then start to think about discharge planning, send a discharge referral, and someone would be discharged hopefully in the next couple of days after that, which is where our 18 days came from. So what we looked at was the national average, which was 16, and having to be hard on myself all the time, I like to set a standard higher than that. So we thought we'd set 14 days as our average length of stay that we'd aim for. For this, we then set a decision point halfway through this, and the point of this was to give everyone in the team a focus to think, actually at this point, how far away are we from getting someone discharged before that day 14, to give us time to resolve those issues. So by doing this, we were able to have physio assessment as it was. The OT we prioritised getting OT assessment earlier, so by day 2 after their surgery. We then looked at how we could do joint assessments where needed. This not only allowed patients to have a reduction in duplication of assessments, but it also meant the physio capacity doubled, because we could then, where we might need 2 physios to see a patient, it now was an OT and a physio together, so the other physio was free to see another patient for another session. We then set a decision point 7 days after their surgery, and this allowed us to then really focus on what happens the next day after this. So more joint assessments, an earlier referral to the discharge team, much more confident what we wanted from them, which allowed us to bring our length of stay down to 13.5 days across that time. So this was something which, as a ward, we all agreed on. Our our femoral fracture nurse, the ward sisters, and our matrons all bought into this model. So we all speak the same language, which means although this is set at 7 days, it is dynamic. So if someone is really good, we're not going to hold them in until 7 days to make the decision. We will bring that forwards. Equally, if someone needs to go to intensive care or they're really unwell for the first few days, we will consider moving that back a couple of days to make that clear decision, which helps our discharge planning for the community. Like I say, it's a shared goal, so everyone knows what we're talking about in the team. When we're talking about the decision point, it's good for the nurses to prompt us sometimes what we're doing. It just stops the therapist getting a bit lost in their own therapy plans. It's predictable. It helps with our discharge planning. We can set this the day they come into hospital. We know what we're working towards, and we can adapt it as we go. And it's also realistic. We could set a goal of 2 days, but we know that most people will suffer with all the things I've talked about, uncontrolled pain, hypertension, delirium, which may affect our ability to discharge plan. So what we found was from our 2017 audit, the national average was 120 minutes. And like I say, we were pretty poor at this point. By 2019, having re-audited, we found that we were shot well past the mark there. So we were getting over 160 minutes for patients in that first week, looking at using our OT therapy time as well, much better focus sessions for these patients. And from our point of view, that meant we were making people more independent. We were getting quicker decisions from our rehab beds. So when we referred to the rehab to the discharge team, it was sometimes hard for them just to see after a few days with only a few input from our team, how is this patient really going to be needing a bedded facility for rehab? By showing that 4 or 5 days in a row, we've seen really big progress. It was far easier for them to make that decision of, yes, that patient is suitable for a rehab bed. So we were getting a good flow from our patients. And more importantly, we were reducing the amount of equipment and care patients were needing on discharge. We also looked at our OT contact, and it went from almost 11 days in 2017 down to 3 days in 2019. So we were seeing really big improvements with how we delivered our service. Really, I suppose the big headline is the length of stay. So what we found was over this time, our length of stay reduced dramatically, as I said, to 13.5 days. And you could argue that is this just something nationally that happened? Did all trusts just naturally sort of improve and get better with the length of stay? When we compared that across the English acute trusts, we actually were able to drop down and meet at the same level and then surpass that. So we were doing better. So there's something we were doing which was better than the national average. After that, we were very happy with ourselves after that. We then started to look at the next standard, so standard 2. We used the opportunity last year during our slight quiet phase when the elective programme wasn't happening after the first wave of COVID. We were then looking at how can we use our time to improve this standard. So what we found was at the 2019 audit, if a physio didn't assess someone, no one got out of bed on that first day. If a physio did assess them, then 70% of patients were able to get out of bed on that first day. So we thought this is something we could definitely work on to improve. So we developed an out of bed project, which included our lead consultant, Mr. Garg, our matron and ward sisters, HCAs. So we got a good team together to work out how we can achieve this. We sent out questionnaires to all the HCAs on our ward, asking them what they felt they needed to do to improve their confidence. We then developed a program.
Can I ask you just to speed up a little bit, please?
Yes, sorry.
Lovely.
So with that, then what we found was by providing a training program over a period of a month, lots of positive staff feedback. Confidence objectively increased from 6 up to 9 on a confidence scale, and most importantly, our out of bed rate, which has been sort of consistently at 60% for the last 3 years, shot up massively to almost where the national average was. So this is something we're continuing on our ward to improve on, and we're hoping to then extend this out to other wards, Ward 12 being our next ward. to do this with. I'll talk a bit about myself. Someone in my team said you need to sort of put this out there. This is this was an article that I was featured in the Physio Professional magazine, and this was basically following a year where we were using this data. We were taking it regionally and nationally to actually show that actually as a trust we're very innovative and are improving our service at a good pace. This combined with me getting onto the it was a research internship this year. It's been quite a successful year for us as a team and as an individual, so we're very proud of that. But the icing on the cake really was one of our consultants and our occupational therapists went to a national conference last month, and it was really good to see the professionals at this conference actually referencing us as a trust, providing excellent sort of service and innovation and progression. So this is something which I'm hoping will help with our recruitment and just raising our profile nationally. We could sort of rest on our laurels there, but we're not stopping. We're looking at being more involved in proper research now. We've done the audits and service improvement. We're soon to start a trial called Hip Helper with the UEA, which will look at involving carers earlier. So in the acute stage, we can get carers more confident before patients go home, which will hopefully improve their experience when patients return home, but also hopefully reduce the amount of care need on discharge, which we know is always one of our biggest limitations to discharging. Our OTs will then take the Out of Bed project to the next phase, looking at delirium, trying to help identify that earlier and how can we improve that on the ward with our HCAs who are excellent and really involved in wanting to do better for our patients. And we'll also be submitting more papers to conference this year to sort of really sort of highlight what we're doing. Just wanted to finish on this really, which was from ESIST, which I really like this. This is a diagram looking at being in hospital. There's a certain time people should be in hospital for, and it's knowing when to get people out before that treatment dose flattens and the risk increases. And I think we do that quite nicely. And I sort of almost use the analogy of IV antibiotics. We are providing a strong treatment for these patients in that first week or so. If that stopped early and patients are discharged too soon, if you did that with IV antibiotics, the risk is that infection gets worse and you're making problems for yourself. So this is about making sure that we provide the right level of care to get people home and doing it right the first time. And again, like the pharmacist or the consultant will be the ones deciding on that, how long that dose should be for. My push is that actually those therapists working with that patient from day zero should really be sort of the key in deciding actually when does that patient, if it's a day or two after being medically fit, it goes against what the D2A model is. But if it's a day or two that makes the difference between having to go to another setting before going home, or we can achieve this in 2 days to get that patient home to where they need, we should really be that trusted assessor on the ward. Similarly for rehab beds, we should have a much greater say in when we feel someone needs that rehab bed rather than going home directly before that point. So that's just a nice little visual that I liked. And I think, yeah, so our decision point really helps with this. We can try and nail that at that right point and say, actually, what are we doing here? And reflecting on that at that weak point means that we can make sure people aren't here unnecessarily. So we've been doing that already, and we have reduced our length of stay. We've also reduced the number of orthopedic outliers. So we often do now have beds free, where 2-3 years ago we had a lot of orthopedic patients on all over the hospital. We now have those down to our base ward a lot more of the time, which does help with our patient care and experience. And I think I've said it all. So there you go. So
Renee, thank you so much. That's a really interesting presentation. It's great to hear your passion and enthusiasm, and there's been some amazing comments in the chat box thanking you for what you've done in bringing, showcasing really the great work that the JPUH has done nationally, and lots of congratulations from all the governors. So I think at this stage, I mean, we could have listened to you all day, I think, because there's so much of interest in there, but we do have others waiting to talk, including Director of Nursing. So
yes,
I can't sort of hold up everybody too much. So I'm not going to open for questions, but if we have questions later that governors might wish to kind of record in the chat box, we can get them out back to you, and perhaps we can get you to respond in that way instead. Is that okay?
That's fine. Thank you for having me. And
Thank
yeah,
you
I'm
so
happy to come back
much,
again,
Renee.
or one of us in our team will come back and give you more updates on elective.
Well, it's really fabulous to hear such great work, and you're making a huge improvement. It's such a big thing for our population because of our preponderance of people over a certain age who are more prone to these fractures. It's making a real difference to our community. So thank you so much.
Thank you for your time.
Lovely. Nice to see you. Thank you.
Thank you.
Great to see you. Anna, can I come to you next to perhaps introduce Paul, because it may be that I don't want to hold Paul up too long, so it may be that you'd want him to do his bit first. I don't know, it's up to you, but I'll come to you first, Anna.
Yeah, absolutely. Thanks, Anna. So we've got Paul here, who is our Director of Nursing, as you know, and Paul's going to give a little bit of an update around our approach to quality and patient safety, not just through the pandemic, but also his kind of vision for the future. So, Paul, I know you're there.
Hello there. Hi.
Well,
morning, everyone. I will try and keep this brief because I'm conscious time is limited, but thank you ever so much for the invite, and thank you for the opportunity to be able to share with you some of my thoughts and what our ambition is moving forward. So I've got some slides, and I'm a slide which is for me to discuss with you. And have you got this already?
No, I'm trying to share it, Paul. I'm just having some technical issues.
Anna's going to share it. Anna's going to share it. There we go. Here's something coming up now.
Fantastic. It's only really for me to talk to, so it's to talk about how the first step is really to keep the patient very much at the centre of everything we do, and so one of my sort of strap lines would be patient at the centre, caring at the core. And I think that's really important, so that what we're doing is that links in with our patient voice as well, so that everything around the patient is built, and what happens is that the patient's at the centre, and what our vision is involves the patient. And I think Hazel uses the frame Whitpit, so where is the patient in this? So therefore keeping that as a golden thread throughout everything we do. So whether it's about the quality of care that we're going to deliver, whether it's about services we want to improve or change, and also about when we review and interact and want to develop things further, quality improvement, research, where is the patient in this, and therefore keeping that patient at the centre. Building on that is about how we use our data, and what we need is high quality and meaningful data. And I've given some screenshots of some examples of where we are currently with manual and paper audits, and how we're moving across and about to launch our Perfect Ward app, which will give us live real-time data around quality indicators, incorporating the patient voice as well. Another example is about, you will see something called Trolley Checks. Now, this is an app we've developed at the James Paget. I'm not aware of any other in the country, and this is to do with both proactive and reactive management of some of our safety checks that we complete. This is an app that looks at particularly resuscitation checks and controlled drug checks. This is both a checking tool, but it's also proactive. So at 3 o'clock in the afternoon, it proactively emails if any of those checks have not been completed to all of the management structure within the ward environment, and also has the ability to escalate. What this then does is ensures not only as an organisation we are checking, and we are checking whether we meet the standards, but we're proactive when we know that we haven't met those standards, still to make sure we keep our patients and our staff safe.
Because
focus on the basics.
That's what you're supposed to see, isn't it?
Oh, sorry. Is there a question?
Yeah, sorry.
We've got someone talking in the background. Could you mute?
I'm trying to. I'm just having some technical issues, so sorry. I'll just keep quiet.
Okay. And so the focus is on the basics. So actually it's about keeping the patient at the centre, but also making sure that we don't lose sight of, good communication with our patients, building on how we interact with our patients, particularly as we go from restricted visiting, opening visitings, and whether we then need to restrict that in the future. But how do we do that? How do we communicate that? Communicating with the families, the patient, but also about our observations, our risk assessments, our patient assessments. How do we escalate when things don't go right or wrong? So how do we do that? But doing that in a culture that focuses in a just manner. So actually, nobody or very few people, I've not met anybody who gets out of bed to do harm to patients. So how do we ensure that we make our staff feel supported, communicate well with our patients and build on that so that it's a just culture? So we ensure people feel safe to raise concerns, but also know that when things don't go as planned, or perhaps there's, you know, significant learning following an incident, that people engage with the process. We share that, we learn from it, and we allow that to help develop and grow, not just the department or the individual, but as an organisation. Patient experience, as I mentioned earlier, is that golden thread that I want to weave throughout all of what we do, whether it's ward-based and ward focus, the standards and quality of care, but also I want it to be that they're involved in having that voice at relevant committees, but also how do we bring that out, the learning, and how do we communicate with them? So we're doing a lot of work around patient experience and involvement. You'll see that we've now recommenced our developing of our quality walkarounds. Now this is where we go to a ward unannounced, and it's about the thought, the feel, the smell of the ward. We walk around the ward, we want to talk with staff, talk with patients, and get that richness that comes across from those interactions. Hear the frustrations. Is it that the window that's broken and it just won't shut, and that's a frustration and it feels like it's been escalated? Or is it that staffing's not quite right? Or is it that the food doesn't arrive warm? You know, whatever those issues are, we want to hear them firsthand and give a wide range of people access to, whether it's an executive, a NED, a senior nurse, but also meet the teams on the shop floor. And lastly, I'll finish by the ambition really is I want to see a sea of green with some dots of blue, but particularly blue around outstanding care and be rated outstanding for caring, because I think this really is in our gift to do. We have an amazing ability to deliver high standard, high quality, patient-centred care. I repeatedly go on the wards and see firsthand outstanding care. The care when someone's helping somebody with a memory, the care of talking to somebody who's distressed. So I really think this is something that's achievable for us. I'm happy to take some questions there. I'm conscious it was a whistle-stop tour.
Thank you, Paul, and thank you for sharing your ambitions for the Paget, because I'm very conscious that you've been in post now pretty much a year, haven't you? But you won't have met many of the governors in person. In fact, there's still some members of the board you probably haven't met in person yet. But it's and of course when you came into the trust, we were very much in the throes of the pandemic from day one. So to hear you talk about the longer term ambitions, I think it's really important for the governors to hear that we have a lot of work going on to try to improve things going into the future that are not just around managing and coping with what nature has thrown at us, if you like, over the last 12 months. So thank you for coming and for sharing that with us. I'm going to take a couple of quick questions, if I might, from governors, just to see who we have. So perhaps Anne, if you could take down the slide so that I can see when hands go up, that would be really helpful. And there's a quick one. I see one there from James. So James, would you like to ask a question?
Yes, thank you very much. Great presentation. I was just typing it in the chat, but it's great to ask it. Thank you. The trolley checker, is that something that the hospital could use as a income stream to sell to other hospitals? Do we have the IP on it?
Yeah, yes, we do. I suppose my ambition is rather than income stream, I think a massive patient safety. So I would like to give it away and let their local IT departments plagiarise it with pride. I'd quite like the Paget logo at the bottom, perhaps, but I think it will improve safety, and I think it's been developed by the NHS for the NHS. So I'm happy to be counter-challenged, James, but I think it's a wonderful gift we can give to each other.
Absolutely. Yes. Sorry,
yeah.
if I could just come back on that. Absolutely agree with the sentiment, but obviously if so much work has been put in it by our staff and by yourselves, you know, we should get a return perhaps. Thank you. Thank you, Chair.
Well, except we are part of the NHS, so I think for me it's very much, and we have benefited too from things that have happened elsewhere in the NHS. So I think the spirit really of sharing is very much at the root of what we do. But thanks for your comments, James. Jane, is your hand up from a legacy, or is that, do you have a question? That's a legacy hand, is it? Okay, you're on mute, Jane.
A question for Paul.
Okay, lovely.
Thank you. Paul, on your walk arounds that you do you speak to patients at any time? And do you involve our patient experience officer in things that you come across?
Absolutely. So when we going around the wards, it's been a bit restrictive, but we're now starting to get these going. And absolutely, it's about hearing the patient experience and whether it's involving the relevant support, so well-being we can escalate to, as well as patient experience, patient advocacy, and really trying to deal with any issues that we come across. So absolutely, it's not just a one-way conversation. It's a two-way and escalating conversation.
Thank you.
Thank you, Paul. And a linked question to that, which came up in the chat box earlier during Renee's presentation, which I'm sure you'd be able to answer, is the programme of when patients will be seen. So this coming back to the fractured femur patients, when they will be seen, shared with a patient, and as importantly with relatives on day one. So in other words, on the day that people come in. Oh, Renee, would you like to answer that one? You're there.
Yes, I'm happy to answer that. Yeah, I can't stay much longer. I will have to go in a moment, but I thought I'd stay on quickly and answer some of those questions. For this one, I was then trying to respond in the box, but I wasn't very quick. So this is something which is readily available on the National Hip Fracture Database website, and there is a document which is aimed at patient, family, relative, carer, with I think there's 12 or 15 questions which to ask of your acute trust, and that has all the main points around when will I get my surgery, who will see me, when should I be expected to be seen by people, and these are things that we're hoping we can start to give out to patients as well. So on admission, we'll start to give people more information so they can challenge us more, because there's nothing I love better than someone asking for more rehab. If patients or family complain about it, that means they care about, or they understand the importance of it. So I'm more than happy for the people to challenge us more on that.
Great, Renee, thank you. Well, and thank you, Paul. I'm really conscious that you've taken time out this morning to come to be with us. So and to Renee too, thank you so much, both of you, for bringing our governance session this morning to life and telling us about what the Paget has been doing and will be doing in the future. Really encouraging to hear that. So thank you for joining us. Anna,
thank you.
Can I come back to you?
Yes, please. Yes, thanks, Paul and Rennie, two fabulous members of our team. I think you'll agree. So a quick update from me. You have got some slides. So we are continuing to run the hospital and manage the pandemic in line with the national guidance, which continues to come in thick and fast. Of course, the most recent being around the changes to the lockdown, with our children returning to school this week, and the differences and changes that's made. We have had, since I last spoke to you, through December and January and February, significant numbers of COVID positive patients through the hospital, far exceeding those we had in the first peak, going up to 179 patients at the maximum. I am pleased to report that we really do seem to be coming much further out of that now, and of course that's linked to the lockdown measures, but also the rollout of the vaccination. Today I was hoping I was going to be able to tell you that we've got single figures in the trust, but we haven't got quite. We've got 11 positive patients in the trust. However, we've moved away from having 6 COVID wards and 2 ICUs to going back to having 1 COVID ward, our infection control ward, and 1 ICU. So it's quite a change to what the staff were managing until really quite recently. So that's very positive. We're continuing to support patients and visitors and continuously reviewing the way we communicate with patients and relatives and visiting arrangements. We're working with our colleagues at the other hospitals in Norfolk in terms of how we can start to switch back on the visiting, because it is very distressing for both patients and relatives not being able to come up. And there were conversations just yesterday between the directors of nursing and medical directors around how we can turn that back on in a consistent way, mindful of the lockdown restrictions and the rates in our local communities. We didn't, of course, just have the COVID issues to deal with. We also had some significant snow this year. And again, the staff were brilliant, but not just the staff. We had a huge amount of support from the local community in terms of helping people get to work and also supporting staff whilst they were here. So that week or so was an added different challenge. We're continuing to provide little treats for the staff. You can see some examples there. And then really importantly, we are now thinking about how we support our staff through the recovery and to plan what next for the hospital and the local community. And we're going to be doing a lot of listening to staff over the next few weeks, sharing some ideas that we've got in terms of how we can help and support them to restart and reset all of the things we need to be doing, but also listening to their views of what might help. Thanks, Anne. I couldn't not tell you about the amazing success of our vaccination programme locally, and Paul, who you've just seen, was absolutely instrumental in setting up our vaccine clinic, currently running out of the Louise Hamilton Centre. When these slides were written, it was just over 21,000 vaccines. It will be more than that now. We're very much rolling the vaccinations out in line again with the national priorities. But one thing that we have done over and above that which has been done in many other places, and in fact we were the first to set up an accessible clinic. So this is a specially adapted clinic for those people in the community with learning difficulties and autism. And Rebecca Crossley, our LD nurse, and colleagues have really adapted an area of the Louise Hamilton Centre and beyond, actually, to make the experience of having the COVID vaccine as pleasant and normal as possible. And we've seen a significant uptake of the vaccine of this cohort, who traditionally, so for example with the flu vaccine, are very reluctant to have their flu vaccine because they are scared. They're scared of the environment. So this has been really positive and has received international acclaim. We've also rolled out asymptomatic testing, COVID testing, to our staff. So this is using the little device there, which is called a lateral flow device. Staff test themselves twice a week, including myself. So it's now out to all staff. And this enables us to identify people early who don't have any symptoms of COVID, but who do have COVID, so that they can isolate, and it reduces the risk of transmission, not just at work, but in the community as well. And that's gone very well. So in other news, just a couple of other things to update you around. So I'm sure you won't have failed to notice the changes at the front of the hospital with our big emergency department extension in the majors area, but also that has enabled us to do some changes inside and to create a long overdue area, which is much more suitable for our children to wait in the ED. So the picture there looks a little bit bland. We are waiting for some beautiful pictures and interactive screens which will go in the paediatric area, but it's bigger. It's got its own separate toilet and changing facilities within there, and it's in a better location in terms of where the paediatric area of ED is. So that's really excellent. And then another thing that we've managed to implement as well, which is really positive, is the mobile cancer van you can see there, and that really is bringing chemotherapy closer to home, and it's really lovely inside. I know it looks a bit like a lorry from the outside, but it is really lovely and comfortable inside, meaning that patients can receive their community, as I say, much closer to where they are, rather than having to come up to the hospital every time. So that was all from me today.
Thank you, Anna, and thank you for giving us that overview this morning of what we've been doing. Are there any questions at all from governors? You have to put your hand up and just bear with me while I scroll through, because I don't want to take the presentation down at this stage, because it will be carrying on with the next slides. But if anyone has a question, either relating to this or to anything that perhaps Paul said, and people had any questions on any of that.
I can see Ben has asked a question, Anna, in terms of what was the community support. So it was basically ferrying people to and from work, so using their 4x4s, which is brilliant. Really helpful.
Yes, in other words, people were picked up from their home by members of the community as a sort of private taxi service almost, and brought to work through all that snow. And we've every winter that we've had snow, we have had such an amazing response from our community. It's not that we really go out and ask for it, it's offered very upfront, which is incredibly generous of people. So yeah, that's what you were talking to.
Yeah, Ben here.
Any other questions?
Just go back on that if I might.
Ben, could you raise your hand so that I can see rather than just come in, because otherwise I can't see who's asking. So yeah, what did you want to ask?
Well, it just to say that sounded such a positive thing, and the link between community and hospital, that it might make a very useful additional newsletter sort of thing, or something along those lines.
Well, that's certainly something that Jane can consider within the governor's newsletter next time, potentially. But we certainly did a lot of thanks out in the community at the time, and on social media. So we did make you know, a big thing of it in the way that we did, and we thanked everyone very, very much. So you know, certainly something. If Jane and Lynn are the people who look at the inside story, so if you want to put that in next time, but obviously it gets a bit late when it's beyond, and the hospital itself doesn't do a newsletter of that kind. So thanks, Ben. Any other questions at all for Anna?
I can see Mary's hand up, I think, Anna.
Lovely. Mary, would you like to come in?
Yes, thank you. I had some really positive feedback from a fellow councillor. Her father was in hospital with COVID, and although she couldn't actually visit him, she was able to speak to him via the iPad, and she thought that was a brilliant system.
Oh, thanks you,
Mary. Thank you.
I mean, that's certainly, we've done quite a lot of work, Anna, haven't we, around trying to keep patients connected to families during the very, very difficult times when, continuing at the moment, when visiting is not as accessible as it was. Is there anything else you wanted to say on that, Anna?
No, and thank you, Mary, for that feedback, actually, because I know we haven't always got it right, and the iPads don't work for everybody, but it is good to hear that, you know, for some people it is really positive, because it's just trying to find as many different ways as possible, because that face-to-face nothing replaces that, does it? So it's what we can do.
Thank you, Mary. I see James's hand is up.
Yes, thank you very much. Yes, could I just ask, if a person has a lateral flow test and it's positive, are they then offered a PCR to confirm that, and therefore the PCR result is taken rather than the lateral flow?
Yeah, so again, we're following the national guidance there. In fact, it's different for different people in different parts of the community, but for healthcare workers, yes, the requirement is to then have a confirmatory PCR.
Excellent, thank you.
Okay, if there are no other questions then for Anna at this stage, we're going to move into the part where myself and fellow Neds talk about what we've been doing. So you'll see my slide up there now, and obviously I've been keeping in regular touch with Anna throughout all these weeks and months, and we've been keeping in touch pretty much twice a week or more frequently if necessary. On top of that, the non-executives who at the moment are not able either to come in so much to the hospital, but they are fulfilling their role virtually, and their role of course is about gaining assurance, and we have weekly meetings to keep in touch with each other, which I found really helpful, and I think the Neds have done as well, and it has enabled me to pass on information that I've received from Anna in a direct way and have questions and chats about that, as well as receiving any information back the other way or concerns. But of course, as well as that, we've continued to have the majority of our committees have kept going, and you'll hear a little bit more about the business from those in the following slides. We have also kept on with our patient experience information. It's a really important part of our board, and we do it in private only because it's really at the moment what most patients would prefer. They don't really want to talk about their individual experience in public, but it is an extremely useful way and an important way for us to hear about not just the good things that happen at the Paget, but things, opportunities for us to improve as well, where things perhaps haven't gone as we would wish. I meet regularly once a month with our lead and deputy lead governor, and I know they're very proactive in contacting you beforehand to see if you have any particular questions or comments to feed into that discussion. One of the benefits of the virtual environment is that I've been able to attend far more regional and national events as well as local events than I would otherwise have to do if it had involved travelling and so on. There's been an incredibly beneficial response, I think, from some of the national organisations to the pandemic by creating different forums, different ways of people connecting and getting information. So I've been taking as much advantage of those as I can. So that's included attending sessions that have been run by NHS providers and by the Good Governance Institute as two examples. There's lots of talk obviously about the white paper, and in our session later in private we'll talk a little bit more about that. We've also created a new committee, a new sub-board committee, in light of the fact that we have 3 very large projects underway at the Paget at the moment, and that includes the HIP2 replacement hospital scheme, the diagnostic centre scheme, and the EPR, the electronic patient record project, which is being embarked on across all the 3 acute hospitals. So we'll give a little bit more information about what's been happening with that particular committee and with those projects when we're joined later by Mark in our private session. So do we have any questions at all for me on those bits, or shall we move on? Very happy to take any questions on what I've been doing. No, can't see any hands up there. So Anne, could you move us on to people and culture? And I think Nicola's going to take us through this slide. Thank you.
Can I just say the only thing we've missed David's slide on quality, because we were going to do the 2 with Paul. So is it worth going back to that before we go to Nicola?
Oh, sorry. That would be really helpful. Yes, I hadn't realised that. It was me not It was. It's at the very top, isn't it?
Yeah, thank you.
Okay, thank you. Sorry, Nicola. David, can we do that one next, please? Thanks.
Thanks very much, Anna. When I saw the slides, I thought I was going to be a warm-up session for Paul. Was my my thought, but it's quite a change. But I will mention Paul on a number of occasions. But just to say to governors that the Patient Safety and Quality Committee continues to meet monthly, has quite a big agenda and big business, and a number of things just on this slide just reflect some of the things we've been addressing. There's been quite a focus on the maternity services, and this all followed the Donna Ockenden report. And in fact, there was a response to that report, but to our board back in January. But we looked at a number of issues that were raised by this report. One was to make sure that there was a champion for maternity amongst the NEDs, and that currently is me. And I meet regularly with Paul and Kirsty, the head of midwifery, to discuss some of the issues. But recommendations included, for example, twice daily ward rounds in the delivery suite, which the consultants responded to immediately, which was encouraging. The NED champion, as I said, and also the appropriate ways of reporting incidents from maternity into board. And there was a presentation by Paul, our Director of Nursing, to the last Patient Safety and Quality, outlining that process and how it would work. And it comes through Patient and Safety Quality Committee and directly then to board. But in addition, we've instigated a way of reporting maternity serious incidents through this system that will go on the dashboard that comes to Patient Safety and Quality and come to board. So there's been quite a few changes in the way things have been addressed for maternity. One of the issues was about caesarean sections, and it's worth perhaps reflecting that Ockenden has very firmly stressed the importance of patient, mum, to be in the decision about caesarean section, and therefore this may actually reflect how our caesarean section rate develops in the future. But we have had a deep dive looking at caesarean sections and the fact that we were to a degree an outlier with a high caesarean section rate. The other next thing to mention is the risk register, and obviously the risk register covers all of the hospital's activities, but there are a lot of risks related to safety and quality, and one of the actions has been to make the risk register web-based, which will make it more efficient and hopefully make it more slightly more active document, so it can be manipulated, that's the wrong word, but looked at and changed as appropriate at regular intervals. And we do discuss risks and risks relative to patient safety and quality on a regular basis. And I think this is a really important way that we get assurance as to what's going on within the trust. We had some deep dives, particularly falls, and actually the presentation earlier was a beautiful example of how to respond to the problems with falls, because fractured neck of femurs unfortunately happen sometimes due to falls in hospital. There was a concern that the numbers of falls had increased recently. In fact, they hadn't. But falls with harm had, and it's something that again we had a really detailed report and look at that with various actions to try and reduce the falls within the hospital, and that was presented by Paul. Pressure ulcers is an ongoing issue, and there's been a slight increase, and there was a deep dive into pressure ulcers, and there are lots of ways of addressing this, but part of the concern had been with the pressure on staff and staffing numbers associated with COVID. But in fact, the pressure ulcer data hasn't changed as much as we had first thought, but it's something that's constantly on our radar and we look at. It may seem odd to you that face fit testing is a concern, but there are changes, regular changes in the masks advised to the trust staff. And face fit testing goes on all the time, but again, there was a deep dive to look at why that was a problem. But it's not through lack of trying to get all the testing done appropriately. The next issue is about complaints, and this is not that we don't deal with complaints, but there was a concern about written responses to complaints which were too slow, and there have been various staffing actions to try and improve this. One of the things we discussed at the last meeting was that we don't just want to look at numbers, but it's the quality of response to complaints that's important, but it's something we're addressing. We had an absolutely superb report from Chris Apps at the last Patient Safety and Quality Committee on behalf of surgery, maternity and children's services, outlining some of their concerns. If I just remember, the recovery following COVID is one of their biggest anxieties. Staff resilience, surgical site infections were concerns, but which they are worried about. But they also reported successes, and there's a new urology suite that's purpose-built. We're very proud of the actual the staff response to the recent research surge in numbers, and also mentioned research. And again, the bit of research was mentioned that they mentioned in that report was that about the fractured neck of femurs. So it's nice to go full circle in terms of the reports that have already been given. I was then going to just lead in with the continued quality improvement and the CQC inspection, and expecting Paul to speak about it, but as he's actually done his bit. But just to say that there are a number of actions taking part, including, as Paul mentioned, the walkabouts, and it was asked who we would speak to, but the NEDs get involved with some of these walkabouts, and certainly I've been asked to get involved as well. So that's perhaps, I think, covers most of the issues from patient safety and quality. Thank you, Anna.
Thank you, David, and my apologies again. I thought it had been uploaded in the wrong order. It was.
So I had it in that order as well.
Just the subtlety. So my apologies for that. But yes, well done for recovering. So any questions at all for David on patient safety and quality, following on from his slide? So James, would you like to come in?
Yes, thank you very much, and thank you, David. David, you mentioned about the mother in the maternity ward being part of the decision making in C-section, and which I obviously, and I'm sure everybody will concur with. You also mentioned about our level of C-sections is higher than national. So do you believe that the two are compatible? Because if we are looking at our number of C-sections, and obviously, so my question is, are the mother's requests actually higher than the ones that we would normally give? Because that is a factor in the number that are being performed.
Thank you, James. That didn't come out of the deep dive into the cesarean section review, though Ockenden is still relatively recent. My guess is actually the norm in the rest of the country, instead of being low around the 10%, may actually increase as a consequence of Ockenden, and that comes from discussions with an ex-president of the Royal College of Obs and Gynae, who's a friend of mine. I was chatting to, I think that will go up, but I don't think there's any evidence that the patient choice or mum's choice had a major impact in our numbers. There've been others about the numbers actual numbers are still relatively small, but there have been multiple birth issues, and there are ways of addressing whether or not we can actually change the numbers of C-sections in those patients as well, all being actively addressed. But it's something we just keep a regular review on.
Thank you
very much.
David.
Thank you.
Thank you. Any other questions for David? Nope. Okay, thank you, David. Can we move then to the slide on people and culture and come back to Nicola? Thanks, Nicola.
Thanks, Anna. So just a few points from me, and hello, everyone. So the first thing on there is about the support for our staff wellbeing. I've been talking about this for some time in all the different council meetings, so you're well aware that it is a priority for the trust to support the staff in the pandemic. We're very aware that they have been working a lot harder, longer, dealing with more deaths than they would like, dealing with wearing all of the equipment, the exhaustion. We're aware of the risk of post-traumatic stress disorder for some of these staff. But I know that you're also aware of the many initiatives that are in place in the Trust to try and support in lots of different ways, the counselling services, the space, and all the little gestures that Anna mentioned in her earlier slide as well, in terms of it's showing that we really value the staff, and that's so important. So they are continuing. Obviously, we want to look at what works best for staff, find out what helps them the most, but it's going to be a range of initiatives, isn't it? People have different needs and ways that they want to be helped. And we also know that managers are being supportive in this process as well. We're keeping, as always, a close eye on sickness rates. I think I've always had this as an item to report to you, but it has come down, and we know that the benefits of that as well in terms of finances for agency staff, etc. When we haven't got staff on sickness, but you'll appreciate that this reporting is in a very different year with COVID, when we've had a lot of staff that have had to self-isolate. Some can work at home, but some obviously have been poorly too. And we really just need to look at what we can see is obviously COVID and what's not. As well, but it's at 3%, so I think I've been reporting to you up in sort of 5 and 6% in over a year ago, so there is some positivity, but there's still work to do there. The Inclusion Network, that continues, and something I don't know too much about actually was the International Women's Day on the 8th of March. Well, I know about the Women's Day obviously, but actually the panel debate I don't know so much about, but it's a demonstration of the work that we continue to do around inclusion and diversity. And the next meeting of the People and Culture Committee in March, we're going to look at the Equality and Diversity Report. And that really looks at all of the interactions we have with all our various stakeholders. So it's patients, the carers and the staff. So it's about improving the patient experience. It's about supporting the workforce and also about inclusive leadership. So hopefully we'll be able to report more on that next time. The implementation plan considered for leadership and management. So that continues from my last point. So we've been doing a lot around leadership for our senior staff, but it's recognised that we can do more for different staff at different levels. So that Graham and the team are looking at, with the education department, looking at more leadership, continuing professional development that we can do for staff there, because we know that the culture is permeated from good leadership, good patient satisfaction, good patient care comes from that, and also job satisfaction for our staff. That all permeates from having good leadership. So we can do some more there to support staff in a range of roles. And then something else I can't say too much about because I don't know. We're looking at the results of the staff survey. Anna Hills has seen the results. So we have a board seminar where we're going to look at the detail, and that's tomorrow, around what the staff have been saying in that survey, and then we can use that to celebrate our successes, but also look at areas, of course, that we can develop on. So that's it, Anna. I'm happy to take questions.
Thank you, Nicola, that's great. I'll just add, we can't actually take questions on the staff survey because the information within it is embargoed until the national publication. But on the rest of it, please, any questions at all now for Nicola would be lovely. Any hands up? Who have we got there? We were told in January. Okay, that's Ben. Yes, that your sickness was 3.7. The underlying sickness was 3.75, and we're now looking at around 3%, which is good news, which indeed it is. Anything else that anyone wants to add? So I think that's excellent. Right, great. Could we perhaps move on to the next slide, please? Which is on the performance. So this is from the finance and performance meeting, and I'm going to actually talk to this slide because Paula can't be with us today. So our last meeting was actually cancelled. So we had a scheduled meeting in January, but it was cancelled because of the incredibly high numbers that we had and the difficulties we were having around the pandemic in the hospital at the time. But we've shifted to this being a bi-monthly meeting in any case, because both the finance and the operational performance reports are anyway shared with board in public on a monthly basis. So it was felt this was the right way to do it, particularly as we're looking at the governance processes for all the committees. We've had to add an extra committee in, which I talked about earlier, which is the Strategic Projects Committee. So we're trying to find ways of ensuring that we look at the things that are most urgent and need most detailed discussion prior to the board discussion, so that the board discussions can be as succinct as possible based on the assurance given by the committees. So the latest position, which was presented publicly from the board in February, and there's some bullet points there relating to that. So one of the good things about the pandemic really has been the approach, the national approach to finance, which has basically meant that we've had our costs met on a kind of regular basis. So we have a block for the year and it's been divided into chunks and we get a chunk each month. I think that's a sort of fairly layman's way of discussing how it happens. Whereas in the past, you know, we had to almost prove that we needed the money in different ways. It's been a much more straightforward process. We are actually in a surplus position at the moment, and that's partly due to the low level of elective operations that have taken place because of the pandemic. And at the end of the year, we are forecast to be in a surplus position, although obviously that can change. We have managed to secure additional capital, and again we'll talk about some of that a bit later in terms of the big projects, but certainly Anna referred to that in the use of the monies to improve our emergency department. That's been the biggest amount of money that we've had. Unfortunately, during the period of the pandemic, we have seen our urgent and emergency care standards deteriorate, and those of you who've attended board will have noticed that deterioration. That is inevitably going to be a difficulty when the hospital was so full and we were unable, if you like, to create the flow and the path needed to actually prevent people having to wait at the front door. However, I would say that I believe that will improve over the next few months, and I know that our teams, the Chief Operating Officer Jo Segersby and her team, and across the hospital actually, have been looking at ways of making sure that those delays can be tackled and that we can get back on track. And we have seen over the last just couple of weeks, we've seen some more promising performance again going forward. So we're hopeful that that will improve. And you'll see there that there is some change nationally. What used to be called delayed transfer of care is now called the right to discharge. So patients now fall into two categories. They're either categorised as needing residence in hospital, if you like, so the reside aspect, but once they meet certain criteria, they are termed as being right to be discharged, and that will obviously see a slight change in emphasis, and René was talking about that partly with the therapies in terms of how we need to work more closely with our community colleagues to ensure that people can get home in a timely fashion. So that is a new change which is gradually being worked out, and we are working very carefully with our community and social care colleagues to ensure that can be an improvement for our patients going forwards. Pleased to say that our cancer standards generally have been maintained during what has been a really, really difficult period. I think we're all very proud of that fact. And whilst we've made some progress in reducing patients waiting over 40 weeks, unfortunately those who are waiting over 52 weeks are inevitably increasing, and I guess will continue to increase for a while until we start to turn the corner. But there is again a huge amount of work going on to try to prioritise those patients who are waiting, and avoiding clinical harm is at the root of that. And each patient is being contacted to make sure that the hospital and GPs and the community all understand whether any further clinical harm is being experienced, and that is being used to help prioritise the list going forwards. But unfortunately, waits are going to be with us for a long period of time, waits for elective operations. It isn't going to be a quick fix. It isn't going to be possible to just sort of turn the corner and with a little bit of effort make that waiting list go away. It will take some considerable time, and I think it's important that governors understand that and are able to articulate that when they're asked the question in the community, because whilst you're seen, and it's really welcome to see the numbers of COVID patients coming down, that doesn't necessarily mean that overnight you can make massive inroads into that waiting list, because we still only have the same number of staff, and we still only have the same amount of space and the same amount of operating slots and so on. So any questions on that? Sorry, I'm trying to read chats. Anne, could you read those out for me? Because I'm getting a little bit, it's difficult for me to see and read the chat at the same time.
Yeah, so Ben's asked, to be clear on right to discharge, is right defined as having that choice or appropriately medically prepared?
Do you want me to answer that, Anna?
Anna, I think that would be a good one for you, because I could probably guess at it, but I'd rather you did the exact answer.
So it's not a right as in a constitutional right. It's a way of defining those patients in hospital who have had all of the care and inputs that are required to happen in an acute setting, and they are now ready to move on to another setting, whether that be their own home or rehabilitation beds or you know, something different. So it's a medical terminology, really.
Thanks, Anna. Okay, any other questions at all on the performance or any of the issues that have been highlighted in that slide? Anne?
Yeah, I just thought I could add to what Anna's just said, as I've just reviewed the patient information for the criteria to reside. So obviously they're going to pilot it for the first couple of weeks and then learn from that. And certainly, you know, making sure the language is really clear so patients understand what that means for them, and then obviously for the staff as well, because it'll be a change for them.
Thank you, and I think that is important, because you know the national changes to terminology are often things that patients struggle with, and it's a good question, Ben, for you to raise there. Any other questions at all from governors on that slide? No. Okay. Can we move on then, please, to, is it audit next, and that would be Stephen. Lovely. Thanks, Stephen.
Yeah, good morning. Good morning to all. I'll just give you a flavour and just talk a little bit around the slide. External auditors, you'll all be aware, have been reappointed, and just to reiterate, that was approved by Council of Governors in January. We've also extended the internal auditors, that's PwC, PricewaterhouseCoopers, by 2 years, basically because we didn't want the trauma of tender in amongst all of the COVID work that's happening in the hospital as well, and they do a great job for us. What we have done is we've increased their fee probably by about 20%, with a view to trying to broaden the scope of the work that they do for the trust, and also to get a greater awareness in terms of risk from them, from the work that they do in other trusts across the country. So I'm hoping that that will improve the service. The internal audit plan for this year certainly will be completed by the end of March, and I'm expecting all of the final reports in at our April meeting, with the view to signing those all off. Particular note the duty of candour, which is also being looked at very carefully by David's committee at Patient Safety and Quality, in terms of performance. They've had a look at, PwC have had a look at the duty of candour work, and reviewed processes, and they were very comfortable with the processes, with a couple of recommendations, being medium and low risk. One being around making sure that all patient safe and facing staff are trained in duty of candour. And just one small technical point around, while this actually does happen within the trust, that the evidence that there's an independent review of classifications is taking place is not being recorded. So we're doing it but not recording it. So it was minor stuff on process. And that's all now being actioned. The key area that we were concerned about was sampling as to how well we do, which links into David's work, is how well we do with duty of candour. And because of change of auditors, the senior partner needed to take that away, and we'll be feeding back to Anna Hills and myself as to whether there was sampling that took place. Internal audit plan for 21-22, I hope to have all in place by April, with a view to spreading the audits across the year. So no concerns there. And external audit and local counter fraud services are all on track, and I have no concerns. And a small amount of good news at the bottom of the slide. You may remember IFRS 16. That's where any leasing arrangements need to be capitalised, which could have a major impact on the finances of a particular trust, and also need to be taken into account when any new projects that involve leasing are brought to the table. Well, because of COVID, that's been suspended until the next financial year, which is one less thing for us all to worry about. So that's a little counter through audit, and I'm happy to take any questions.
Thank you very much, Stephen. Any questions at all for Stephen? Let's have a look on the participants. Any hands up? Anyone want to make any points there? No, thank you then, Stephen. I mean, it's really helpful, I think, to have that overview from all of the NEDs. And you'll remember that it's our opportunity as non-execs to share with you the assurance that we've received, and to demonstrate, if you like, that we're well, our knowledge of and our involvement in the business of the trust. So I hope you found that helpful. Are there any other questions that people would like to ask of Anna, myself, or any of the NEDs that have spoken this morning around any of the items that we've looked at? Has everyone felt they've had sufficient time to ask their questions? Excellent. Okay, so our next item, I think, is for Lynn to come. Is that the right one, where we're talking? Lynn, you're going to tell us a little bit about the NHS Providers Workshop for Governors that you attended. Is that right?
Yes.
Welcome, Lynn. Thank you.
Thank you. Morning, everybody. I must admit, I've slept so many times since I attended this workshop. It's hard to remember exactly what happened. And the paper that I did, I hope you've all had a chance to have a look at that, and to look at the presentation from the workshop itself. It was really, really interesting. Excuse me, attending the workshop. It is a good opportunity to hear what's happening in other trusts, what other governors are doing to try and improve their communications and engagement with the members of the public and what have you. And I just wanted to sort of say, I know it's been difficult with all the local restrictions because of COVID and what have you, but hopefully all the governors have been thinking about what can we do to try and improve our engagement when we are actually able to start going out and meeting the public, which hopefully won't be that distant. Thank you.
Thank you very much, Lynn. And it was really good that you were able to attend that event on behalf of governors. I find the NHS providers events very worthwhile. They're usually very well planned and thought through, and they usually have very good speakers. So I'm glad that you also felt that helpful. Anne, would you like to come in?
Yeah, just really a question to Lynn. So, you know, part of the benefit of going to some of these events is just seeing how we compare and what we can learn to continue to improve. So did you get a feel for, you know, all of the work that we've already done, how that does compare with others?
Yeah, as I mentioned in my paper, the 2 showcases that they did, we've also done something really similar in our own way, but we just haven't sort of gone out there and shared what we do. So, I mean, the 2 showcases, there was one about the communications, how governors interacted at their team meetings and what have you. They developed a team charter. Well, at one of our previous councils, I think the last one, we also spent a lot of time working and developing our own rules for engagement and behaviours, which basically was our own charter. So done that, got the T-shirt. And the one about engaging.
Oh, you've gone on mute, Lynn.
Lynn, I think you might have hit your mute button by mistake.
I apologise.
That's all right.
Yeah, I was saying about engaging with the younger people, with students. Mike did a lot of work producing that leaflet, and then we went into the college once or twice. I think we could do more work to engage with youngsters, but again, we've already been looking at that avenue. So as a council and as a trust, I think we're well up there with everybody else.
Yeah.
But
yeah.
we just keep it to ourselves, perhaps,
yeah.
rather than sharing it and being one of these showcases.
There's a lesson there for us, Anne, isn't there, around?
Yeah.
Because I think as a trust generally, not just with our governors, but perhaps at board level too, we're maybe not as proactive as we need to be in terms of showcasing the things that we do. Because we kind of just assume, well, they're good, so everybody will be doing them. So maybe that's something perhaps when our new comms director comes in and we can think about focusing, you know, to have some things there and some time to be able to think about how we can put that out there a little bit. Does that make sense?
Yes. Well, I was also thinking, obviously, from a sort of becoming a full-time trust secretary, that's the sort of thing, you know, supporting some of these events that I hope that I'll have the capacity to do. So, yes, we absolutely, we do presume that everybody's doing better than us, but I don't think that's necessarily the case, and it would be good to get that out there.
So we could see you and Lynn and Jane starting at a next event then. So,
yeah.
Brilliant. Okay, that sounds really good. Any questions for Lynn on her presentation? Anything anyone wants to ask on that? No? Okay. So shall we move on to the next item? So this is about our Remarkable People's Award. Anne, would you like to summarise where we are with this one?
Yeah. Sorry, we just missed one. The one before is around the elections and the constitution, but there's no paper.
I didn't mean to. There we go. Yeah. Election then, first of all. Yeah.
Yeah, so I'll be brief. I mean, Lynn's just mentioned really that, you know, the council has had challenges. Obviously, the pandemic has been difficult for everybody. We're not working in the way that we normally do, and I know some of you have struggled with that face-to-face links with us and with membership. I think we've done as well as we could do. You know, the council was obviously only elected for 1 year, but you have met your statutory responsibilities. So if we think from the beginning of September, you know, we have got a new membership strategy. We were planning to do some virtual engagement in January, but obviously that was the time of the second wave. Our regulators have been really clear through their they've had a number of letters called reducing the burden. They've been really clear that governors should only be engaged and linked to the pandemic. You've recruited 2 new non-exec directors, so obviously they're here. You've recruited the external auditors, which Stephen has already mentioned. So we've got a reduced council this year. We changed the constitution last year, and actually I think we should keep with that reduced council for the time being as we move into the next election. So I will start planning those. I need to have conversations with providers and see who's going to offer us the best deal, and I hope by the next council at the beginning of May I'll have a really clear timeline for that, because obviously we'll be electing for a 3-year period this time. But you know, attendance has been good, the engagement with you all has been good through the virtual meetings that we've had. You know, it will be nice to think that we'll move to some face-to-face meetings at some point before you finish, but I just wanted to highlight that there will be a plan for the elections, and again, not to be too hard on ourselves, because whilst we haven't maybe been out and about doing the member engagement we would have liked to have done, we have been in the middle of a huge pandemic, so the council has achieved a lot in terms of its statutory role.
Thank you, Anne, that's really helpful. There we go. Yeah, any questions at all for Anne on any of that around our constitutional plans for the election? I think it all sounds very sensible, and I've certainly noticed, I think, a greater engagement with a smaller number of governors. There does seem to have been, you know, better attendance, I think, even though it's been virtual. So that's really encouraging to see. Okay, if there are no questions on that, by the way, I haven't asked Jim. Jim is there, is he? And he is able to ask his question. Is there anything that Jim needs to ask, not necessarily about that point, but anything that's come before? Is Jim all right?
I'm listening very attentively.
Yeah.
I'm hearing about, I don't know, 50–60% of the presentations because of the echoing back.
Okay.
Some are very, very clear. Yeah, the chief executive is very, very clear. Paul Morris, I could hear as clear as anything. The first guy, Rennie, I missed half of what he said. This is not satisfactory listening, because I can't go out and make the coffee. I have to listen, and it is difficult. I have to think of another way of overcoming this, but that's my problem.
Well, what we'll do, Jim, is we'll make sure that Rennie's presentation is sent out, so that you get a chance to see it, because you wouldn't have seen it on the screen unless you've seen it anyway, have you?
Yeah, we certainly we let Jim have the presentations.
I'll get a copy, but there's a lot of questions I'd like to have asked Rennie, and I know he's gone now, but there we are.
There's still time, Jim, so you know you can always have a chat with Anne afterwards, and we'll make sure that your questions get asked and answered. Is that okay?
Yeah, okay, thank you very much.
Lovely, thank you, Jim. Okay, so are we now on to Remarkable People, Anne?
Yes.
Is that right?
Yes.
Beg your pardon, thank you.
So this is a report that I present to governors every year. So we do run a very successful awards ceremony here. We didn't do it last year because of the pandemic, because it didn't feel right that we celebrated a very small number of staff when actually everybody was going above and beyond. Nicola chairs the organising committee, and we have 2 governors on that as they're a key part of it, because we do have a governor's award. It's been interesting because our new wellbeing manager comes from a big trust in London, and she's now joined the committee, and I'd sort of made the assumption that other trusts had these big events too, but actually her trust didn't. So she hadn't come across a big celebratory ceremony in the way that we have, and certainly the feedback she's had from staffers, we really do need to run that this year. I'm going to be very sad to hand this over. So we have an organising committee next week, and that will be my last one, because obviously I've been with it since the start, but that will move over to the new head of communications. But what I'm asking for today is I'm just setting out the process that we've had in terms of the award of the Governor's Award. We have the two governors that are on the committee. So we've got Lynn, who's been part of the committee for a while and has been really integral to some of that work, and particularly supporting the comms team, because whilst everyone sees the event at the end, there is a huge amount of organisation to make sure that that runs successfully. Jan was previously on the committee, but she's moved across, and we've welcomed Carol, who's obviously a staff governor, so that she's part of that decision making, and they together confirm who the Governor's Award is provided to when at the end of the judging. So just seeking your approval for the process that we utilise, and obviously for the presentation on the night. We haven't got the date confirmed yet, but it's likely to be in October, but we'd like to ask the current lead governor to present that, as obviously the decision will have been made with this council.
Thank you, Anne. That's a really good summary of where we are. Jane, would you like to come in?
Just to say, well, with Anne, we were there right at the very beginning of the remarkable people. So I was at the start of it with you and with our director of nursing at the time. Now I just feel that we've gone such a long way with this, and it is amazing what has been achieved. So if the next comms officer does such a good job, well then brilliant. And as for doing the presentation, I'd be delighted to come in October. So I just thought I'd let you know. So thanks, Anne, for your hard work anyway. Thank you.
Thank you. That is echoed by us all, I know. I just hope that by October we'll be able to have an event, but obviously at this stage we can't be absolutely sure that it can happen in that way. But it will be wonderful if we can get together in October and celebrate staff in the way that we'd like to. But everybody happy to approve then the process by which Governor's recommendation and award will go forward. That's lovely. Thank you. So we're now going to talk, I think, about the performance review. Again, this is the process rather than the detail. So am I able to stay in this bit? Yes. I think, can't I?
Yeah, so at the last meeting, the council agreed the process, all the paperwork and the time frame for undertaking the performance reviews for this current year. What I'd done then was I delayed the start of that process, recognising that we were in the pandemic, and we did recognise that actually we might need to delay that further, which is what happened, because at the point of us sending out the stakeholder questionnaires, we were still really challenged with the number of positive patients, so it didn't feel right to be asking for lots of comments at that time. So what you've got here is a revised timetable. So obviously we need the outcome to be confirmed by the council before you finish this term of office. So if I take you over to the final page, you'll see that I've scheduled that for the 11th of August. Now that's currently not a formal council meeting. It's scheduled in all your diaries as a sort of farewell, but I think we'll use a little bit of that for a formal council meeting. And that's also the date I'm going to be working to for the election results too. So that'll be something we'll confirm in your diaries, and we'll likely need to change the Governor's Nomination Remuneration Committee date as well. So we've got one already scheduled in June, but we've potentially got some discussions around non-exec appointments as well, so we might well need to move those, but obviously I'll have conversations with the committee. So it's just a revised timetable I'm seeking approval on, please.
Any comments or questions to Anne? If not, are we all happy to approve that paper and the revised appointments schedule? Thank you very much indeed. Okay, so I'm now going to go to the item for any other business. Jim, can I come to you first?
Well, any of the questions I've got for Renee?
Yes, I can pass those on, Jim.
Yeah, we'll take those outside the meeting, I think. Is that okay? Any other business? Anyone like to raise their hand? James.
Yes, not necessarily any other business, but may I just make sure that it's recorded for everybody to know, and thank the whole team, everybody, for looking after our patients within Suffolk and Norfolk over this very, very difficult period, over this second wave. And it's tremendous news that Chief Executive mentioned that we today only have 11 patients compared to what must have been a tremendous effort by James Paget Hospital to look after 179. So if it could just be recorded, our absolute gratitude, that would be very kind. Thank you very much. Thanks, Chair.
Thank you, James. And I know that we all echo your thanks there, and it's nice to have that recorded. So thank you very much indeed. Okay, so I think we now come to the end of the public part of the meeting. Sorry, we've got Yvonne. Did you want
Yes,
to...
sorry. Hi, I couldn't find my hand earlier.
That's okay, no problem.
I just wanted to say, you know, as a staff member having worked in intensive care for the second wave again of the pandemic, I'm hugely proud of our Paget family, who always pull together so well in every aspect to look after the patients in the local community. And I'm delighted to hear of the recovery plan going forward. Just something to raise is, I know with the staff, and we obviously haven't seen the report from the staff survey, but I do know, and I don't know how you would get around it, I do know that a lot of people that do complete those forms are office based, and I don't know how we're going to get that to the clinical people, because I think it may, and again I haven't seen the results, it may not portray the true vision of all staff members, but I don't know how we could change that. Maybe adding a survey to pay slips or something like that, so we know we can get, but I know a lot of clinical staff especially don't get to fill they don't get the opportunity, or the time rather, not the opportunity to complete those surveys. So thank you.
Thank you, Yvonne, and really appreciate your comments there. Anna, did you want to respond at all?
Yeah, just to say that part of the analysis is also looking at where the responses are coming from, which parts of the trust, the professions of individuals completing the survey as well. So we are able to see that level of detail, and then that will be, you know, if needed, part of our planning going forward as well.
But very much appreciate your positive comments, Yvonne. Thank you for that. And good to hear, and obviously the results of the staff survey will in due course come out anyway at board, won't they, Anna? So we'll perhaps hear a lot more about that going forwards into next year, but we definitely know, whatever the outcomes, really, we have a huge plan of work ahead of us, and we really want to continue to make lots and lots of changes and improvements to actually benefit our staff, which in turn will benefit our patients going forwards. So thank you so much for all your contributions this morning. What we're going to do now, I think, is close this session, and then we will allow perhaps a 10-minute break, and then if we are now at 10:45, could we perhaps reconvene at 11? 11? Should we say?
I need to check Mark is free at 11.
Okay, that's a good idea. So if we could go away, make ourselves a cup of tea and have a stretch, and we'll come back on the other invitation at 11 o'clock. Thank you all very, very much indeed. See you shortly. Bye.
Bye. See you shortly.